Stanley, Dr. Thornton was involved in research and clinical care of children with hyperinsulinism and became the clinical director of the Hyperinsulinism Center. During his career, he has been involved in research that has helped elucidate the genetic basis for forms of familial hyperinsulinism, developed and validated diagnostic testing methodologies, including the intravenous acute insulin response test, selective pancreatic arterial calcium stimulation, and 18F DOPA PET scanning. He's also validated treatment options, including octreotide therapy and partial pancreatectomy. As a result, Dr. Thornton has published more than 30 peer-reviewed articles about hyperinsulinism in journals including Nature Genetics and the New England Journal of Medicine. In 2003, Dr. Thornton joined Cook Children's Hospital in Fort Worth, Texas, where he is a distinguished consultant and holds an endowed chair supporting his work to develop the Cook Children's Congenital Hyperinsulinism Center. Over the last 10 years, I've had the opportunity to work with Paul in other areas of pediatric endocrinology, but have recently come to rely on his expertise in caring for children with severe forms of hyperinsulinism. And so today the title of his talk is Hypoglycemia, Differential Diagnosis, Diagnostic Evaluation, and Treatment Options. Please join me in welcoming Dr. Thornton.
Thank you very much, Brad. That's a very nice introduction. Today I'm going to talk to you about hypoglycemia, and I'm going to just start off and show you my disclosure slide. So I have done some consulting work and worked as a speaker for Teva Pharmaceuticals, and we are going to talk about off-label use of certain drugs, in particular octreotide and 18-fluorodopa, which is not actually even FDA approved at the moment. You know, at lunchtime meetings, people can get a little sleepy. So I like to give you the takeaway points so that, in case you missed the end. So point number one is that hypoglycemia is a biochemical sign, not a diagnosis. And that's very important because a lot of people will think they've done their job when they identify hypoglycemia, but in fact, you're really only starting. Takeaway point number two is that hypoglycemia is very dangerous and can cause brain damage, which leads to takeaway point number three, which is you should never discharge a patient from your care who has hypoglycemia until you know the cause or you have a plan in place to make a diagnosis. In other words, if a kid comes into the ED, you don't send them home saying they had fever and hypoglycemia. You need to do something a little bit more. Because what people forget is that hypoglycemia is not an outpatient diagnosis. And so saying, I'll send you to the endocrinologist in 2 weeks is generally not a good plan. Okay, so for today, I'm going to talk a little bit about the physiology of hypoglycemia. I'm going to think about it as to, what happens in the newborn period and go through a sort of a time frame of hypoglycemia in the newborn and then in the older age group. And we'll talk a little bit about the physiology and mechanisms of defense against hypoglycemia. And we'll talk about the etiology of hypoglycemia at the different ages. And then I'm going to spend the last third of the talk talking about hyperinsulinism, and which is probably one of the most severe and dangerous forms of hypoglycemia. So the first thing when we talk about hypoglycemia is how do we measure the plasma glucose? Well, the vast majority of times what we do is we use screening tests, and these are the Dextra sticks. And these are point-of-care glucometers that were developed to diagnose and manage patients with diabetes. And so the blood glucose range that they work very nicely in is 80 to 400. But when you get down to the hypoglycemic range, and a blood sugar of around 50, they're plus or minus 15 milligrams per deciliter, even the good ones. And so, you don't really want to be making a diagnosis of hypoglycemia based on a glucometer, because a blood sugar that says it's 50 could be as high as 65 and as low as 35. And so if you've got someone in whom they're either at risk or you highly suspect hypoglycemia, if you get a D-stick under 60, you really want to send it to the lab for confirmation, because you'll be surprised at how many 55s you get that are really 45, and you could go ahead and do some further studies at the time. So that leads us into the next question, which is, what is the definition of hypoglycemia? And really, the good news is that there is no single definition to cover all eventualities. The bad news is there's no single definition to cover all eventualities. And so this is a problem because people will say, well, I get confused. What do I do in the newborn period? What do I do at a week old? What level do I treat the blood sugar to? So really, your definition depends on why you're defining the number. So, for example, most people define a number to diagnose. At what level can I diagnose the cause of the hypoglycemia? Then there's the treatment level. What level do I have to treat the sugar to feel comfortable that I'm in the safe range? And then the lawyers want to know, when the kid doesn't get into Harvard, what number can I sue the doctor over? So I like a practical definition. So instead of one number, I have several different numbers I like to think about in my head. The number one is, at what level of glucose can you make a diagnosis of the cause? Because you can't diagnose the cause of hypoglycemia if the patient is not hypoglycemic at the time. There are a few occasions when you can with modern technology, but as a general rule, the patient needs to be hypoglycemic at the time. And so once the blood sugar goes down to 50 milligrams per deciliter or below, if you draw a critical sample at that time, you can diagnose the cause of the hypoglycemia. Now, when you've got a patient with a hypoglycemic disorder, the next question is, what level do you want to treat for? And actually, so you want to aim to treat into the normal range. And the normal glucose in children beyond the age of 48 hours of life is actually 70 milligrams per deciliter and above. So our target should be to aim for normality, which is 70. So a lot of times, you'll hear our families in the emergency room coming in saying, well, I've got hypoglycemia. I was told to come in if my blood sugars are low. And the doctor will do a check and it's 55. And they'll say, no, your blood sugar is fine. You don't have to worry about it. Well, they do have to worry about it because when you're treating someone for a disease, you don't want to treat them to the bare safest level. You want to treat them into a range that when they fail their treatment, they're still safe. So if your treatment goal is 70 and they hit a 60, now you know you need to change their treatment, but they're not in any danger. So the therapeutic level is 70. Now, what about the level of hypoglycemia that can cause brain damage? And the answer is nobody knows that number for several reasons. Firstly, as you all know, hypoglycemia does not always cause brain damage. I bet you everyone in this room has seen either a hypoglycemic baby or a hypoglycemic child, and they're absolutely fine. And so, on the one hand, you could say, well, we've all seen kids with hypoglycemia, they're fine. What's he getting so worked up about? On the other hand, those of us who see kids with specific hypoglycemic disorders will realize that the incidence of damage can be very high. And so why is it that there's such a difference? Well, it's because it's not really hypoglycemia that causes brain damage. It's cellular energy failure that causes brain damage. And so the brain is using glucose, lactate, and ketones in order to generate energy. And when the cell is not able to generate energy and ATP levels fall in the cell, a cascade of events occurs that can cause cell death. And so it really isn't what is the glucose level that causes brain damage, it's what's the energy level that causes brain damage. But we can't measure intracellular ATP in the blood, so we have to look at the fuels that we use, which are, as I said, glucose, lactate, and ketones. But it turns out that there's even more. What do we need to use our energy? We need oxygen. So if you now get a combination of low fuel levels, i.e. glucose, and low oxygen, it turns out to be much, much more dangerous. And so there's been some very nice studies done in animals that show that if you make a rat hypoglycemic for 10 minutes, there's a certain rate of brain damage. If you make them hypoglycemic and anoxic for 10 minutes, then the rate of brain damage is dramatically increased. But most surprisingly of all, they found that if you make them hyperglycemic and anoxic, that is, in fact, by far the most dangerous combination, which is why you'll see oftentimes the neonatologists will look at these sick premature babies who can get quite hyperglycemic just from stress and be very worried and be giving them doses of insulin. And we're thinking, 200 is not that big a deal. But it turns out that if you are a premature baby and you have the opportunity to plug your ET tube or pull it out and you become anoxic and you're hyperglycemic, that's very, very dangerous. So how do we prevent hypoglycemia? Well, naturally we eat and we absorb carbohydrates. But once we've gotten through that phase, we get into the postprandial phase, and now we have to rely on our reserves. And so the big reserve we have for sugar stores is glycogen in our liver. And a typical 4 or 5-year-old kid is going to have 4 to 6 hours of glycogen reserves in their liver. Small baby, maybe 3 to 6 hours, and an adult, maybe 8 to 12 hours of glycogen reserves. When we've used up our glycogen, we make glucose from precursors such as glycerol or the amino acids, and this is called gluconeogenesis. And then the other thing we do is we try and decrease the amount of glucose that we need, and there's 2 ways we do that. The number 1 way is we use alternate fuels. So we'll, for example, metabolize fat into beta-hydroxybutyrate, and many cells, including the brain, can metabolize beta-hydroxybutyrate. But the other thing we do is we can actually decrease our glucose utilization. So, for example, the brain, when the blood sugar starts getting down to 55, 50 milligrams per deciliter, will start to slow its function. And so this is why some of the early neuroglycopenic symptoms are of lethargy or an inability to concentrate. And they've done psychometric testing on people that when they deliberately bring their blood sugar down, their function, it's a little bit like drinking. You know, we all think we're fine after 1 beer, but we really aren't. Well, the blood sugar is the same. As it starts to come down, the brain starts to not function so good. And it's only when you get down into the 30s and 40s that you're likely to have a seizure or become unconscious. But on the way there, you have diminished function. And so all of these systems are controlled primarily by hormonal systems. So insulin, for example, drives glucose into the cell. It's an anabolic hormone. Cortisol and growth hormone will aid in breakdown of fat and the generation of amino acids to be presented to the liver for gluconeogenesis. Glucagon causes release of glycogen from the liver. And that's a nice fact that we use in diabetics. When we see a diabetic with a low blood sugar and they can't eat, we'll give them glucagon to raise the blood sugar. And what you're basically doing is releasing glycogen. And then epinephrine and norepinephrine, again, will encourage fat breakdown, but also release glycogen from the liver. So the first question is, how do you make a diagnosis of hypoglycemia? I like to get interactive, so if I don't have volunteers, I pick on people, especially at the back with the laser. So any volunteers, how do we make a diagnosis of hypoglycemia? Come on, everybody, it's an easy one. You check the glucose. That is correct, because like we said, hypoglycemia, it means low blood glucose. Okay? What really is important is how do you make a diagnosis of the etiology of hypoglycemia, and that's a little bit more complicated, because you've got to check both the blood and the urine for the key intermediary metabolites and the hormones involved in glucose regulation and in gluconeogenesis, glycolysis, and fatty acid oxidation. And so typically we call this the critical sample, and it's called critical because it must be done at the time of the low blood sugar. So if your glucose is less than 50, you draw your critical sample. It's a lot of stuff in the critical sample. And basically, you know, if you envision in your head, you know, a time curve of what happens with glucose after you eat. So we talk about you eat and you increase absorption of glucose. While you're absorbing your glucose, your insulin levels are going to be high. And then when you finish absorbing glucose, you're breaking down your glycogen, and then you start to have gluconeogenesis and fatty acid oxidation. So there are 2 critical components in the determination of the etiology of hypoglycemia. Number 1 is how long is it since you last ate? So if it happens in 2 to 3 hours, you've got to be thinking about insulin. 2 to 4 hours, you've got to be thinking about glycogen problems. If it starts happening 12 to 18 hours out, you're thinking fatty acid oxidation defects or disorders of gluconeogenesis. So the timing is very helpful, and then the critical sample. And I would say 99% of the time, if you get the critical sample off at a time of hypoglycemia, we can make the diagnosis. Now, that's very important because I don't know if any of you remember the bad old days, for example, before we did newborn screening for fatty acid oxidation defects. You know, there was a condition called medium-chain acyl-CoA dehydrogenase, and 25% of people died when they had their first acute episode or decompensation. So can you imagine if you had an MCAD kid, you had the opportunity to get the critical sample, you didn't do it, and then Dr. Miller had to bring him into the hospital to do a fasting study, and the kid dies during the fasting study, it wouldn't be so good. So you got to take your chance every time it comes. So if you can't remember what to do, then at least remember to draw some blood and stick it in a green tube, a red tube, and an EDTA tube, and grab some urine, and then you can figure it out later. Or even better, which is what we do in our institution, is we have a hypoglycemia panel in the computer. So the doctor in the emergency room says, oh, the blood sugar's low, draw the hypoglycemia panel. They don't even know what they're drawing half the time. So they just click on, in the computer system, hypoglycemia panel. It tells them how much blood and how many tubes, and they send it off. And that's very important. And so it's really, if you're in an area where hypoglycemia might be common, you might want to think about having something like that done. Now, I'm going to talk a little bit about the different types of hypoglycemia that we'll see. And I'm going to start with transitional hypoglycemia, because transitional hypoglycemia is the bugbearer of hypoglycemia to us endocrinologists. Because what happens is if you talk to your average neonatologist, and I forget to tell you at the beginning, I always pick on neonatologists when I'm talking. So if you talk to your average neonatologist, they'll say, yeah, we see tons of hypoglycemia. Every baby has hypoglycemia. We couldn't possibly work up every baby who has hypoglycemia. And when you read the guidelines from the American Academy of Pediatrics and the Canadian Pediatric Society guidelines, they're all about protecting normal babies from having too many investigations. If you read them carefully, that's what the bottom line in the guidelines are. And they're not about diagnosing the sick babies who have hypoglycemia and separating them from babies with transitional hypoglycemia. So that's what I'm going to teach you about today, is how to make that differentiation. And so we're going to talk about transitional hypoglycemia, which is a physiological variation of normal, transient hypoglycemia, which is forms of hypoglycemia that only exist for a little while, be it several months or several weeks, and then more persistent forms. So what is transitional hypoglycemia? So this is basically physiological adaptation to extrauterine life. So we all know that in utero, the fetus is in a different metabolic milieu than in extrauterine life. It's in a position of anabolism. Everything is about growth and development and laying down stores and growing. And so the fetus blood sugar is a little lower than the maternal glucose. There's facilitated diffusion across the placenta. And so in utero, it's very advantageous to have a high insulin level as a fetus, because that drives glucose into the cells and stimulates growth. But the minute you're born and that cord is clamped, it becomes very disadvantageous to have high insulin levels. And so transition in terms of hypoglycemia is that period of time where there's this adjustment from intrauterine to extrauterine life, a time of continuous supply of glucose, almost endless, into a time of a sudden interruption of the glucose supply when they clamp the cord, followed by feeding of pure fat with almost no carbohydrate for the first 24 hours, with almost complete starvation for a normal breastfed baby, till eventually the milk comes in, and then there's reasonable nutrition. So that's a pretty tough time. And we know, for example, that babies in utero will have glycogen levels of about, I can't remember, it's 50-fold higher than at the end of 24 hours. So they just dump so much glycogen out of their liver over the first 24 hours. And so, there's a lot of hormonal changes. You get a rapid fall in insulin with a rapid rise in glucagon, epinephrine, norepinephrine, and the enzymes required for glycogenolysis, gluconeogenesis, and fatty acid oxidation all have to be induced. And typically by 24 hours, all of those enzymes are induced, and a normal baby will be able to maintain its blood sugar in a normal range, which gets us to the point of what is the normal range of blood sugars in babies. So there's a lot of papers that look at this, but one I think that's really nice is a nice meta-analysis done by Alcalay et al., and it was published back in 2006. And what they basically did is they tried to look at all of the papers that had ever been published and tease out where, could they get individual glucose levels, could they do the calculations on their own, and what sort of babies were in them. Were they purely breastfed babies? Were they healthy term babies? Were they SGA? And so what they came up with is that for the normal glucose levels in the transition period, at around 2 hours of life, the mean glucose in the baby drops from about 70 in the cord blood down to 56, with a calculated fifth percentile of 28. By 24 hours, that blood sugar mean is up to 63, with the 5th percentile being less than 40. And by 48 hours, that mean glucose is up to 67, with the calculated 5th percentile being less than 48. And so what's very clear is that what goes on in the first 6 to 12 hours of life is very different than what goes on afterwards. And it's very important we understand that. We know that 30% of babies will have a glucose less than 50 milligrams per deciliter in the first 12 hours of life. And there's been some really nice studies done by Lubchenco and Bard who show that if you follow all babies that go through a nursery and you find out who has low blood sugars and you follow them out, that less than 1% or around 0.5% of babies will develop a glucose of less than 50 milligrams after 72 hours of life. So the important thing to get out of this is that what goes on in the first 12 to 24 hours of life is completely different to what happens afterwards. And so on the one hand, we can have an attitude about low blood sugars at 2 hours of life, but we can't take that information and equate it all the way through the neonatal period. And unfortunately, that's what happens some of the times, is that people say, well, we know the definition of hypoglycemia at 2 hours of life is that the average baby is 56, and that lots of babies will have them down into the 30s, and then they take that information and they just use it at 7 days of life, and it's a completely different thing at 7 days of life. So how do we treat transitional hypoglycemia? Well, basically the guidelines tell us that if a baby is symptomatic or unwell, so if you have a sick kid or you have a baby with symptoms of low glucose, and their glucose is under 40 in the first 6 hours of life, and we would believe under 50 after 24 hours of life, that they need IV glucose to treat that low blood sugar. If they're asymptomatic and have a glucose less than the 5th percentile for age, so that's going to be basically 5% of babies. You just feed them, repeat the glucose an hour after the feed. If the glucose has come up very nicely, then you just check pre-feed and monitor. If the blood sugar is not coming up and they're staying low, then you might want to consider IV therapy. And so that information is really nicely documented in all of the guideline statements. What the guideline statements don't really tell us about is how do we differentiate between transitional hypoglycemia from pathological hypoglycemia, because most of the kids who have pathological hypoglycemia will also have it in the first 24 hours of life. And so that's very important. So one of the ways to look at it would be that if a baby is having symptomatic or asymptomatic hypoglycemia of less than the 5th percentile or 50 milligrams per deciliter that persists beyond 48 hours of life, they need to be investigated. Or if they needed intervention with IV fluids, IV glucose to treat hypoglycemia, they need to be investigated. It's hard to argue a physiological process requiring intravenous glucose. So if you have to do an intervention such as intravenous glucose, then we believe these babies should be investigated. So now we're talking about, we know that 1% or less than 1% of babies will have a blood sugar less than 50 by 48 hours of life. You're not going to be measuring blood sugars on every baby. You're only going to be measuring blood sugars on at-risk babies. So if you have an at-risk baby who's still in trouble, they need to be investigated. Now, how do you investigate them? Well, we already said before, if they have a spontaneous glucose less than 50, you do a critical sample. But what happens if they don't? So, for example, the American Academy of Pediatric Guidelines would say that if a baby has 3 blood sugars in a row of over 50, you can send them home. They're good to go. You don't have to do anything more. And we would disagree with that, and we have data to suggest that that's wrong. So if they don't have a spontaneous glucose, you need to do a fasting study. So how do you do a fast in a baby? Well, actually, everyone says it's very difficult, but it's actually very simple. All you really need is a baby, a nurse, a breast or a bottle, 3 dextrose sticks, and 1 lab glucose, and you're good. So it's pretty simple. So the 6-hour fast, I won't bore you with the details, but we did a nice study in Cook Children's looking at how long do you need to fast babies to make the diagnosis of perinatal stress hyperinsulinism, which is the most common cause of hypoglycemia in this age group. And the question was, do you have to fast them for a full 9 hours, or would a 6-hour fast be okay? Because a 6-hour fast basically means that you skip 1 feed, and then you measure the blood sugar at 3 hours, 4 hours, and 5 hours by glucometer. And if it's good, then you do a lab glucose at 6 hours. If the lab glucose is less than 50, you do your critical workup, you make the diagnosis. If the lab glucose is greater than 65, you send them home. And if it's between 50 and 65, you got to keep going and do a 9-hour fast. So that's when you need a few extra dextrosons. So if you follow this rule, we call this the 6-hour to reflexing to 9-hour fast, because in endocrinology we're used to reflexing tests. So for example, if we've got if we do a screening free T4, we might reflex to the TSH if the free T4 is low. So the idea is that you save money by not doing the test on everyone, but on the ones who need it, you do it. So this has a sensitivity to detect patients with disease of 100%, which is what you're after in a dangerous condition, but a lower specificity of about 66%. So some people who did not have the disease needed to have the 9-hour fast to prove they didn't have it. And so, the question is that a practical thing to do in a neonatal, in a NICU? And we believe it is. And what you're trying to pick up really is the kids with the transient hypoglycemia, because transient hypoglycemia is always pathological. And the type of people who have this are infants of diabetic mothers, kids with perinatal stress-induced hyperinsulinism, and these are and these babies are not always LGA or SGA. They can sometimes be AGA, but they'll often have a history of asphyxia or fetal distress. They may have maternal hypertension. It could just be late pregnancy-induced hypertension, and the mothers may have been on therapy. And then the premature babies are a slightly different category. Now, when we talk about persistent forms of hypoglycemia, we're talking about the congenital or acquired forms of hyperinsulinism, babies with hypopituitarism. So about 1 in 50,000 babies will have hypopituitarism and will present with hypoglycemia, prolonged jaundice, and in boys maybe a small normal or micropenis. Then we're talking about, you'll occasionally see kids with growth hormone deficiency presenting with hypoglycemia in the newborn period, and kids with ACH deficiency or resistance sometimes in the newborn period, but more often a little bit later in age. Then the glycogen storage diseases, type 0, 1, 3, 6, and 9, all can cause hypoglycemia. Disorders of gluconeogenesis, the most common would be fructose 1,6 bisphosphatase deficiency or pyruvate carboxylase deficiency. And these will also have associated lactic acidosis, so there are other clues. And then the fatty acid oxidation disorders, which can be divided into disorders of the carnitine cycle of beta oxidation and ketone utilization. And there's about 13 to 14 different fatty acid oxidation disorders around now. And then, of course, mitochondrial disease. The rule for mitochondrial disease is that it can cause any symptom at any time in any body. And so no matter what they have, you always have to put mitochondrial disease down. Now, in the older children, we'll tend to see more commonly idiopathic ketotic hypoglycemia. This is basically a substrate deficiency. If you fast anyone long enough, you can make them hypoglycemic. And so idiopathic ketotic hypoglycemia really refers to kids who become hypoglycemic with ketosis before they should. But all their systems are working, it's just accelerated. And then primary adrenal insufficiency is something that we'll see presenting in the emergency rooms and in older children. And here are all the disease causes, but you have to remember steroid therapy. It's actually remarkable how many kids get steroid therapy and don't actually get stress steroid coverage. So, for example, if you give an asthmatic 5 days of steroids, you can suppress their adrenals for about a week. And so typically they get over their illness and they're fine, and so you never know that a problem can happen. But theoretically, it can happen. So one big question is how often does hypoglycemia occur in children in general, and how often are you going to see it? So we did a nice study in our emergency room. It took us 2 years. During that time, there were 224,000 patients came to our emergency room. We're a little busy down there. Approximately 20,000 kids, or 8.7%, had a glucose level drawn because either the attending thought it needed to be done or it came part of a package of comprehensive metabolic panel. 160, or 0.82%, of all the kids that we did a glucose test on had hypoglycemia that was not otherwise known about. So we're not talking about diabetics here. We're not talking about kids with glycogen storage who come into the emergency room for an ear infection. We're talking about first-time presentation of hypoglycemia that nobody knew the patient had before. So 160 out of 224,000. So this is basically 80 a year. It's 1.5 a week in a horribly busy emergency room. So not that common. So 85 of those patients had a complete evaluation done. I know Dr. Miller is thinking to himself, my God, that's terrible. They only worked up half the kids. And I know the emergency room guys are going, oh my God, that's amazing. They worked up half the kids. It turns out that half of the kids who got worked up were worked up in the emergency room. So they actually only worked up a quarter of the kids. The other quarter were admitted and the endocrinology team worked them up. And then half of them didn't get worked up at all. 76 had confirmed true hypoglycemia out of those 85. And of those 76, 16 had a serious endocrine cause that needed ongoing treatment. So this was 21% of the kids who had who had a workup. Now, we have to assume that our emergency room doctors are very good, and they sent home everyone who didn't need a workup because they knew they were healthy. And even if that were the case, then the worst case scenario is that 10% of kids who come into the emergency room with hypoglycemia for the first time ever have a serious cause to the hypoglycemia. Best case scenario, depending on how you look at it, is 20%. So, is there an easy way to differentiate between those who have a problem and not? Well, it turns out when we analyzed our data that if you look at beta-hydroxybutyrate levels, in the kids with serious endocrine disorders, they all had suppressed beta-hydroxybutyrate less than 1 millimolar. And if you look at the kids who did not have serious endocrine disorders, so these were all the idiopathic ketotic hypoglycemia, the vast majority of them had beta-hydroxybutyrate levels greater than 2 millimolar. Now, did we see every type of hypoglycemia possible? The answer is no. We didn't see, for example, any glycogen storage kids. So it's not really fair to say you just need a glucose and a beta-hydroxybutyrate. You need one more thing, and that is you have to examine the patient. So here's our new algorithm that we think will work effectively. If someone comes into the emergency room with an episode of hypoglycemia, you do a plasma glucose and a beta-hydroxybutyrate. You can either do a point-of-care beta-hydroxybutyrate because they are very good now, and if you don't have them, you do an in-house chem lab beta-hydroxybutyrate. If the glucose is less than 50 and the beta-hydroxybutyrate is greater than 2, and they have a normal physical exam, then you can conclude reasonably that it is unlikely they have a serious underlying disorder. Now, what does a normal exam mean? It means that their height has to be appropriate for their family, not just the population. So short stature could be caused by growth hormone. Growth hormone deficiency can cause hypoketotic hypoglycemia. But some kids will be able to make ketones. So they have to have a normal height. They have to have no liver enlargement because glycogen storage kids will have elevated beta-hydroxybutyrates. So they have to have a normal abdominal exam, no cleft lip or palate, which might be a sign of a central pituitary problem. If those kids ever come back again with another episode of hypoglycemia, when you've told the mom, make sure you feed the baby, make sure she drinks sugar-containing fluids if she's vomiting, if they have a second episode, they need a full workup. If they have a glucose less than 50 and a low beta-hydroxybutyrate, they need a full workup. And if they have a glucose less than 50 and a beta-hydroxybutyrate greater than 2 but an abnormal exam, then they need a full workup. And so this is very interesting because if you look at the cost-benefit of doing it both ways, if you do it the old-fashioned way, which is that everyone gets a critical sample, in our institution the cost of a critical sample is $1,250. Now that is how much it costs us to do it. Like how much we charge for it, don't even go there. Considering that a comprehensive metabolic profile costs $1,500. So we won't go into those details. But the actual cost of the critical sample is $1,250. So for us, we diagnosed 16 patients out of having to work up 160. So it costs us $12,500 per patient that we diagnosed. Now the question is that worth it? Now when you look at the glucose plus beta-hydroxybutyrate, because the glucose point of care is about $50, the beta hydroxybutyrate is about $50 to $100, and then you have to do some critical samples on kids who didn't need them, plus the critical samples on the ones who did need them. Turns out you reduce the cost per diagnosed patient down to $3,250. Now that's a pretty good price to pick up all kids with a serious endocrine disorder. Because what's the cost of a misdiagnosis? Well, actually, if you get brain damage from hypoglycemia, you're probably looking at a lifetime cost of $5 to maybe $10 million. And then the medical legal cost, you got to add in the lawyer's 35% share and all the other costs that go. So you're talking about missing one of these kids and letting them get brain damage being very expensive, never mind the humanitarian aspect. So let's move on now to congenital hyperinsulinism. And as I mentioned earlier, this is a disease that commonly presents in the newborn period. It's the most common cause of persistent hypoglycemia in infancy. There isn't good incidence data in the US. We believe it's about 1 in 30,000. But the good incidence data comes from Belgium, where they studied every kid in the country and discovered it was 1 in 50,000. But what's very important about this condition is the high rate of brain damage. So in the old days, like in the 80s and 90s, 50 to 60% of these kids were brain damaged. Nowadays, in the best hyperinsulinism centers, so that's a place like mine where we have a multidisciplinary team all ready to go, everyone's educated, we're still seeing 20 to 30% brain damage. And if you look at like average centers who don't have a multidisciplinary team to look after these kids, you're talking about 30 to 40% brain damage. So it's a serious disease. There are lots of different genetic defects that can cause this, and there are multiple mechanisms that you can inherit hyperinsulinism in. So, we all know autosomal recessive. Well, these are the genes, the ABCC8, KCNJ11, and this is the gene that causes short-chain acyl-CoA dehydrogenase deficiency, which can cause hyperinsulinism. And then dominant genes, ABCC8, glucokinase, and GLUT1. And then glucokinase and GLUT1 typically will be a spontaneous mutation. 80% of the patients will not have a family history, even though it's a dominant mutation. And then there are some causes of this disease that affect the same genes that cause monogenic diabetes. So, for example, HNF4 alpha and HNF1 alpha can cause different types of MODY, and mutations in the ABCC8 gene can also cause neonatal diabetes. So it's become very interesting, the molecular etiology. The clinical features, basically in babies, the problem is it's very hard to tell a hypoglycemic baby from a non-hypoglycemic baby till they get into neuroglycopenia. And then they have jitteriness, twitching, lip smacking, eye flicking, sort of subtle seizures leading to full-blown tonic-clonic seizures. More often than not, they'll present with apnea or lethargy and unresponsiveness. In older children, of course, we have the classical adrenergic and neuroglycopenic symptoms that we're also familiar with in our diabetics. Now, with hyperinsulinism, 40 to 60% of these patients present in the first week of life. 30% present later than that. However, I believe that when you look at this 30%, at least 25 to 40% of them presented in the newborn period, but their blood sugars settled down and they were sent home. And then 10% present any time up to late adulthood. I saw a kiddo, 12-year-old girl, was like just a little bit slow. I mean, a nice kid, but, on the surface she looked like she was normal. But when you started talking to her, you realized she was a little naive and innocent and a little slow in the ways of the world. And she had epilepsy, and she'd been attending the neurologist for years. She'd been in and out of the emergency room with seizures. And one day, some dumbass emergency room doctor decided to check a blood sugar on a 12-year-old with epilepsy. I mean, like, who'd have thought? And sure enough, the glucose was 30. And they went, whoa. And they did a workup, and she had hyperinsulinism. And she'd had it, when we looked at her history, she'd had it since birth. So, one of the things that's happened is that there's this idea that glucose screening in patients with seizures is not economically viable. Well, it turns out that the data came from infants and children with febrile seizures, and somehow it sort of slipped over into general seizures. And so many times kids will come to the emergency room and not have a glucose done when they have a seizure, and they probably should. So how do you diagnose hyperinsulinism? Well, they have persistent hypoglycemia, short fasting duration. They often have increased glucose utilization, meaning they need more glucose than a normal baby to keep their blood sugar up. So a normal term baby needs 4 to 6 milligrams per kilo per minute. An older child to an adult is 3 to 4, and adults are 2 to 3 milligrams per kilo per minute. Insulin levels will be greater than the lower limit of detection. So if you can measure insulin, it's too much. If the blood sugar is low and you can measure the insulin, it's too much insulin. They'll have low ketones, less than 2 millimolar, and free fatty acids less than 1.5. If you give them glucagon at a time of hypoglycemia, their blood sugar will rise. And that's a very valuable test because really there's only one thing that happens in, and that's in children who have too much insulin. Typically those children are diabetics. But occasionally it's a hyperinsulinism baby. And the reason is that by the time you become hypoglycemic, you should have used up all your glycogen already. And the only reason you don't use it up is if insulin is preventing its release. They'll have low ketones. IGF-BP1 levels will be suppressed. Certain forms like glutamate dehydrogenase will have elevated ammonia. Some kids may have protein sensitivity, so they get hypoglycemic when they eat protein, but they don't when they eat regular food alone. And then you can do an acetylcarnitine profile on urine organic acids, and this will not only pick up all your kids with fatty acid oxidation and some of the other disorders that cause hypoglycemia, but will help identify the kids with SCHAD-mediated hyperinsulinism. The treatment is medically is diazoxide. This is a KATP channel opener, and this prevents insulin being secreted. The problem with diazoxide is that it acts on the proteins that are encoded by the genes that are mutated, and so those proteins are often either not there at all or they're not normal, so many times diazoxide won't work. It takes 5 days for diazoxide to take a full effect, and so you have to get these kids on treatment. After 5 days, do a fasting study to see are they cured or not. Another treatment is octreotide. This is a non-FDA indicated use for octreotide. The doses are 5 to 20 mics per kilo per day, and it can be given as frequently as 4 hourly, and sometimes you can get away with 6 to 8 hourly. Occasionally, some kids will be responsive to octreotide, but the effect of a single subcutaneous injection is so short-lived that rather than giving them 6 injections a day, we put them on a pump. And of course, that's a non-FDA approved use of an insulin pump, is to put octreotide in it and infuse it. But actually, it works very nicely in some kids. Now, if medical therapy doesn't work, then you're left with no option but to remove the pancreas. And so if you can't keep the glucose safe on a reasonable program, you need to do surgery. Now, the definition of a reasonable program is different for everyone. So, for example, some people believe that it's reasonable to put a G button in, feed the child continuously 24 hours a day with oral feeding on top of it during the daytime, and they say that's reasonable because if we do that, the blood sugar is above 70. But if that G button disconnects once, that kid's glucose is going to drop very low, and if a baby has hypoglycemia with a seizure, there's a 50% chance of brain damage. So in the first few months of life, this sort of conservative plan is a little dangerous. So if you need surgery, it turns out that most of the people who need surgery have mutations in the KATP channel, and the good news about this is that it causes 2 different types of disease, what we call focal and diffuse disease. Focal meaning a small part of the pancreas is affected and the remainder is normal, and diffuse meaning the whole pancreas is affected. And why that becomes important is that if you have focal disease and you can find the focal lesion and remove it, you can cure the patient with only taking a small amount of the pancreas out so they don't get diabetes. On the other hand, with diffuse disease, if you leave any of the pancreas behind, it's going to have abnormal beta cells, and so they have hypoglycemia. So how could you possibly have mutations in the same gene that cause different pathological forms of hyperinsulinism? And the answer is it requires 2 different events to happen. The first event must be that the father is a carrier for the ABCC8 gene mutation and transmits his broken gene to the baby. And the second thing is that the mother is not a carrier, but in a certain part of the pancreas in development, there is loss of the maternal allele. Now, we know this happens in lots of different cancers. So there are, for example, many different cancers in which you get loss of heterozygosity and you lose a maternal allele or a paternal allele. And in this case, if it happens and the paternal allele has a mutation, you get a focal lesion that secretes too much insulin. So how do you find it? You use a non-FDA approved drug. And when I say not even approved, I'm not even talking about off indication. There is no indication for 18F-DOPA. So it is only done in centers that have an investigational new drug license to use it. And there's currently only one that has it in the United States for use in children with hyperinsulinism, and we are currently filing for one. We have all the paperwork is about to go in, so we're anticipating in 3 months we'll have 18F-DOPA. And it's able to differentiate focal from diffuse very nicely, over 88% of the time. And when you combine it within either an MRI or a CT scan, so most of the PET scanners now have a built-in CT scanner. So when you pop the baby in, inject the 18F-DOPA, you do the nuclear med scan, and then when it's finished, you do a quick CT scan, and you can co-localize, and you can see the lesion very nicely. And here's a nice picture. It's not really a nice picture, but you can see here the 2 kidneys, and this is the pancreas here. And you can see that in the Untitled process of the pancreas is the focal lesion. Now, that looks like it's a huge focal lesion, but it turns out that the brightness of the spot doesn't really equate to the size. It all depends on how hot your 18F-DOPA was when you injected it. There are a lot of different factors. But the point being, if you can go in and operate on that and leave the tail and the rest of the body, you can cure that patient. And so the advantage with 18F-DOPA scanning is you can do minimal pancreatectomies, leaving as much normal tissue behind. You need frozen section to guide the surgeon as to when he's got all the tissue out. So you need a pathologist who can tell the difference between focal and diffuse. You need a surgeon who's willing to stand back and wait a half an hour for the result of a frozen section, and then take another little piece of the pancreas out, wait another half hour. That's a very rare surgeon who'll do that for you. And when you do that, the cure rate is over 80% with almost no diabetes risk. And so this is a very complicated process that's required. So to summarize for today, hypoglycemia is not a diagnosis, it's a biochemical finding. If you don't know the cause, it's very important to draw the critical sample at the time of hypoglycemia. And if you are not in a position where you can get the whole critical sample done, then a glucose and a beta-hydroxybutyrate will go a huge way in telling you who needs further investigation or not. Never discharge a patient until you make a diagnosis of the cause of hypoglycemia, or refer them to someone who will. And remember, this is an inpatient disease, so don't send them home. You admit them, especially if you're in the emergency room. And outside of the neonatal period, and we're talking 72 hours, 10% of people who have a low blood sugar will have a serious cause for that low blood sugar. And we are done. Thank you very much. I'm sorry, I went 37 seconds over my time. Yes, sir.
That was an excellent presentation and a good review. Starting from neonate all the way up.
Thank you.
Are there any data on hypoglycemia unawareness in the pediatric population? Do you see them in your population?
I'm sorry, hypoglycemia in who?
Unawareness.
Oh, hypoglycemic unawareness. Yeah. Actually, it's very interesting. So with diabetics, we know in the adult population, and it turns out it's the same in the pediatric population, that every time they get a low blood sugar, that requires them to activate their counterregulatory hormones, that counterregulatory hormone response is blunted for up to 5 days. And so that every time you have a second hypoglycemic episode within those 5 days, the ability to get the adrenergic symptoms, which is basically what makes the kids aware that they're having a low blood sugar, becomes blunted. And so if you start seeing kids who have hypoglycemia more than once every 3 or 4 days, over a short period of time they develop hypoglycemic unawareness. And actually, this is very true. That 12-year-old girl I told you who was having the seizures, she would be sitting there functioning completely normally till she'd have a seizure. Not a symptom at all. And actually, even now that we've treated her, and she's been treated for 6 years, she still has hypoglycemic unawareness. So it absolutely does occur. Of course, every neonate has hypoglycemic unawareness because they really don't get adrenergic symptoms. And so, and kids who have, say, for example, elevated lactates when they go hypoglycemic, they also may not necessarily have symptoms. So, yes, it absolutely does occur, and the more often they have low blood sugars, the more unaware they become. Yes?
How did the birth get out of the neonatal period? She was identified with hypoglycemia, but you said it just got better, or?
No, I mean, she had low blood sugars in the newborn period, and they were dropping down into the 40s and 50s, and so presumably they fed her a couple of times, and she had 2-3 glucoses over 50, and that meant 51, and so she was sent home. And one of the problems is that the reason we don't like a single definition is because people say, okay, hypoglycemia is 50, therefore if you're 51, you're not hypoglycemic. Well, you're not normal if you're 51. And a normal newborn very quickly gets its blood sugars up into the 70s. And so, so yes, there will be some normal newborns who will drop their blood sugar below 50 in the second day of life. But when you see how frequently it occurs after that, it's really, really rare. And so, I mean, that's part of the problem, is that people sort of feel that if it's over 50, you don't have a problem, and that's not really true. And so really we should be thinking about, instead of the AAP guidelines saying, if you have an at-risk baby, because remember, we're not talking about all babies here, we're talking about at-risk babies. So if you have an at-risk baby, really they should be saying is that when they've had 3 normal blood sugars, i.e. mean for age, which is actually 65, then you could say they don't have a problem. But if they're having 3 blood sugars of 50, 52, 53, that is not a normal baby. And you're already in an at-risk category. So that's what happened to her, is that someone looked at her and said, well, it's not 49 or 50, it's over 50, and they sent her home.
It looked like if you want to do that critical sample, it's about 7 cc's of blood, and then you tap them for the urine at the same time.
Yeah, you can get the urine in the next hour or two, actually. And actually, there's a few things. So depending on the age, so let's say, what sort of kids do you see? Babies. Okay, so that's a good one. So what do you do if you've got babies? Well, there's a couple of things. A, the acylcarnitine does not technically have to be done at the time of hypoglycemia. Growth hormone levels are spontaneously elevated for the first 7 to 10 days, so they don't have to be done at the time of hypoglycemia. So really you're talking about getting the insulin level, well, obviously a glucose to confirm, insulin, and beta-hydroxybutyrate. Now, if your hospital has a good chemistry department, they can get glucose. In our hospital, we can get glucose, lactate, cortisol, and beta-hydroxybutyrate on 1 cc, and we have to send our insulin out, so that's another cc. But if your hospital did the in-house insulin assay, then because you don't have all the dead space to send it off to different labs, you could do most of it in 2 cc's. And the thing with the neonates is that the vast majority of hypoglycemia is hypoketotic. So if you see a low beta-hydroxybutyrate, you're almost certainly talking excess insulin secretion. And so, and then it's and now once you've suspected, you've got a kid and you say, okay, this kid has a problem, now you're down to so few babies that if you have to go back and do it again and get a bigger blood draw, you can. So I would say in the NICU, you really want to, your money is on insulin and insulin and beta-hydroxybutyrate. You can come back and look at cortisol later by doing a stim test. You can look at growth hormone on a random test. You can get the acylcarnitine and the urine organic acids in the next hour or two. So, I really, there should be what we call a neonatal critical sample as well, and that's a much more limited blood draw. You don't need to get the C-peptide. That's, 2 cc's on its own. It's very rare a baby in the NICU is going to be given insulin by, the nurses, unless you're in Canada. Wasn't there a Canadian nurse did that one time? She gave something in the NICU, I remember. Yeah. Any other questions?
So I have one practical question. Is when do you give parents a glucometer to help evaluate this sort of a problem in the process of trying to work something?
Essentially never, because sending them, if you see them and they have hypoglycemia, if you follow cardinal rule number 3, you don't discharge them till you know the cause, because it's so dangerous, so they shouldn't be going home. And B is that the glucometers are useless. And their most important is to remember, do not give them to teenage girls who say that they get dizzy and lightheaded in the afternoon. Because, a cold hand, there's so many causes of a false low glucometer reading. It drives you nuts. So I believe that there's no role for glucometers, and that, in fact, the only role for the glucometer is in the diagnosed patient on treatment with your goal of keeping that blood sugar above 70, and when they're hitting glucometers below 70, you need to change your therapy. So I don't think it has a role in the investigation. All right. Well, thank you very much.